Good afternoon. Welcome to the Senate Committee on Health and Human Services. Madam Secretary, please proceed to call the roll.
Senator Lang, Senator Wynn, Senator Stone, Senator Titus, Chair Doniate.
I am here. And then please mark Vice Chair Nguyen and Senator Lang present when they walk in. Thank you. Good afternoon, everyone. Welcome today to the Senate Committee on Health and Human Services. I presume we have a full room for my pediatric cancer bill. So, no, we have two hearings today on Senate Bill 221 and Senate Bill 239. So, in general, we will start with Senate Bill 221 and then we will move to Senate Bill 239, just to give everyone the fair chance for their knowledge, both in this room, in Las Vegas, and in Carson City. We do have a hard stop at 5 p.m. So depending on how the bill hearing goes, we will try our best to accommodate for the second bill hearing, but we could also pivot depending on how far we go, just because we do have the state of the judiciary, which the legislators are going to be called down to. So again, I do have a few housekeeping announcements. As I mentioned, agenda items may be taken in a different order than listed, or they can be postponed or removed from this agenda depending on how today goes. We ask that public comments be kept to 2 minutes so that everyone interested in speaking can be accommodated and ensured that we get through the agenda in a timely fashion. You may also submit public comments in writing, either in addition to testifying or in lieu thereof. If you wish to testify, you can always sign in at the door and provide a business card to our committee secretary. And if you do not testify, you may also want to sign in so that we have a record of who you are. And just as a reminder, you can always submit documentation to support your testimony. When testifying, please turn on the microphones on and off to speak and to listen. And of course, please state your name for the record. And then anyone who wishes to receive copies of the committee exhibits should go to the Nevada Legislature's website, and you could also request copies from our committee manager. And finally, please ensure that you're turning off your electronic devices and putting them on silent during the meeting. So as I mentioned, we're going to be starting with Senate Bill 221. So I'll go ahead and open the hearing on Senate Bill 221. This bill revises provisions relating to Medicaid, and today we have with us Ms. Annette Logan, who is the founder and CEO of Cure for the Kids Foundation. So please begin.
Chair, do you mind if I make a comment?
Not at this time. We are going to go ahead and proceed with the bill hearing. So
It has to do with the agenda for today.
we are currently on Senate Bill 221. So
But if I could just make a couple of quick comments, please. We're going to be hearing.
Senator Stone, if this is in relation to another agenda item, we can entertain that right now at a later time frame. But right now we're on Senate Bill 221. So at this time, again, we will go ahead and turn it over to Ms. Logan, who is the founder and CEO of Cure for the Kids. So please begin.
Hello, thank you for having me here today to testify on behalf of Senate Bill 221. I'm Annette Logan Parker, and I'm the founder and CEO of Cure for the Kids Foundation, and I'm also the current chair of the Nevada Rare Disease Advisory Council. I've been in Nevada for 25 years and have been in the healthcare industry that entire time. So today we are going to talk briefly about Senate Bill 221, which I believe is a very simple solution to a complex problem that we have in Southern Nevada as it relates to how children access care for pediatric oncology and other rare disorders. So the history of Cure for the Kids Foundation, we are a direct result of my own experience with my son, who had a catastrophic medical situation. Thankfully, he is healthy and productive now as a Clark County firefighter. And although our journey was a success in the end, it was full of frustration, heartbreak, and pain that led to financial ruin and, more importantly, an entirely new perspective on how children with cancer and rare diseases should be cared for. So today we're here to talk about provider types. And currently, the Southern Nevada Childhood Cancer Program is restricted to provider type 20. And we are hoping to amend the Medicaid service manual to include an additional provider type to add specific language for a billing guide and rate methodology for outpatient childhood cancer and rare disease centers. And the goal of this is to ensure that the billing guide and the administrative burdens associated with that are more in line with how kids with cancer are currently treated in today's environment. So currently there are 16 other provider type 17s in Nevada. So this bill would be adding an additional provider type into a system that already exists and would allow us to create a billing guide and rate methodology that is better suited for the care that's actually provided in today's environment. It's a simple solution to a complex problem. So if there's any questions, I'm happy to entertain those.
Thank you so much. Do we have any questions regarding the bill? Senator Tai?
Thank you, Mr. Chair. Thank you for bringing it forward. Just wondering, I'm not able to see a fiscal note on it. Was there one submitted? I know this policy, but still.
Ms. Logan, can you
My understanding is, yes, that there is. I spoke to...
And your name for the record, please.
Oh, it's yes, Annette Logan Parker for the record. Thank you. I spoke to Stacy Weeks from Medicaid yesterday and said that she did submit a fiscal note. I have not had a chance to take a look at it. But I can tell you that Richard Whitley and the entire team at Medicaid, as well as the managed MCOs who manage Medicaid beneficiaries, are all on board with having this new billing guide, specifically to relieve the many administrative burdens that are associated with it. I'm happy to provide some of those examples if you're interested.
Thank you so much. Dr. Titus, did you have any other follow-up? Ms. Logan, can you just, I think it's important to curate as to like, what are the frustrations that you have encountered as an organization? I think that's important for committee members to understand while we are trying to work through the fiscal process as well, but I think it's important to convey how that plays down to your organization and why this is important.
Certainly. Annette Logan for the record. So primarily the rules that we must follow are based on what you would consider healthy children, if you will. So just for simplicity purposes, we give nephrotoxic chemotherapy in our center every day, which means that it's toxic to the kidneys. And the billing guide indicates that you can do one urinalysis in a certain period of time. We must often do 8 to 10 in that same period of time to ensure that we don't damage the kidneys, ultimately could result in a kidney transplant or even end of life for that child. And so what happens is we either have to get denied, appeal, and there's all of this administrative back and forth on things as simple as the standard of practice for these kids. And another example would be the billing guide indicates that children with fee-for-service Medicaid are only allowed so many high complexity visits within a time period. And every time that the child comes to our center, it's a high complexity visit. And so what happens is there's a huge burden on this side of the state as well as the provider, because we have to go through the process of appealing, denying, and ultimately there's a tremendous amount of labor expense that's spent on both sides of the equation to just be able to provide the children with what is considered standard of care. And I could go on and on if you want more.
Yep, Senator Titus.
So thank you for that. So at the end of the day, what this bill is trying to establish is so that you can, if you change your provider type via Medicaid, you could actually perhaps get reimbursed for some of the costs of actually doing the care that you already do?
Yes, and to alleviate the back and forth. I mean, the administrative burdens are immense in the healthcare system today.
So how many how many other agencies such as yourselves administer this type of care?
We're the only ones in Southern Nevada.
So at this, and nobody in the north?
Well, it's childhood cancer is treated through Renown in the north. It's more of a hospital-based outpatient system. So the care in Southern Nevada is accessed very differently than it is in other parts of the country.
And so how many providers do you think it would affect?
It ultimately affects Cure for the Kids Foundation. We currently employ all of the practicing pediatric oncologists in Southern Nevada.
All right, thank you. Thank you, Mr. Chair.
Thank you so much. Any other comments or questions on this bill? Senator Stone.
Thank you. I just want to thank you for bringing this forward. You know, we're talking about a pediatric population, and you don't want to be caught in getting treatment authorization reviews and making sure their renal function or kidney function is sufficing for a nephrotoxic drug. So I'm all in favor of giving you the latitude to have the appropriate billing codes and provider designations in order for you to provide this necessary service for our kids that are suffering without any delays in therapy. So I appreciate you bringing it forward.
Thank you, Senator Stone.
Thank you so much. If there are no questions, we'll go ahead and move on to testimony and support. So just as a reminder, we are on testimony and support of Senate Bill 221. Just a reminder to please limit your comments to 2 minutes each, and we will start with support testimony from the physical location. So if anyone in support for Senate Bill 221.
Thank you, Chairman Donate and members of the committee. My name is Wiz Rizard, Deputy State Director with American for Prosperity here in Nevada. On behalf of thousands of our activists throughout the state, we thank you for the opportunity to testify today in support of Senate Bill 221. Although we believe state-run health care, such as Medicaid, Medicare, should be limited and accessible to those who are most vulnerable in our society, we urge you to vote yes on SB 221, which seeks to simplify and streamline billing and reimbursement rates under Medicaid for clinics that provide services primarily to children with cancer and rare diseases. We anticipate this bill will have little to no effect on overall spending while aiming to help make it easier for medical facilities such as pediatric cancer care providers to receive reimbursement under Nevada Medicaid. So please vote yes on Senate Bill 221, and we greatly appreciate the bill sponsors for bringing this forward. Thank you.
Thank you so much. Anyone else in Carson City? Las Vegas? And virtually.
If you would like to testify in support of SB 221, please press star 9 to take your place in the queue.
Good afternoon, Chair Donate and members of the committee. For the record, my name is Aaron Rook. That's E-R-I-N-R-O-O-K. I live in Senate District 3. I work as a story bank organizer for Battleborn Progress, but I'm here today to testify in support of Senate Bill 221 as an individual. This bill would help to ensure that children with cancer and other rare health conditions who are covered by Medicaid have access to the care they need. We are lucky to have an organization like Cure for the Kids finding creative solutions to address the limited resources available to families struggling with these conditions. The least the state can do is to ensure that these critical services are appropriately reimbursed so that they can continue to be available to children who need them. As an adult with a rare genetic health condition, I understand how difficult it can be to find a healthcare provider with the knowledge and experience to provide your care. I have something called epidermolysis bullosa, a rare genetic skin condition that can be debilitating and even fatal for children who inherit 2 copies of the affected gene. Because I only have 1 copy of the affected gene, I didn't require specialized care as a child. But even as an adult with a milder form of the disease, I've never seen a provider who was familiar with my condition. There's only 1 specialist in the entire country who treats adults with EB, and spoiler alert, he's not in Nevada. So until Nevada's healthcare infrastructure evolves to meet the needs of Nevadans, it's imperative that we use all the tools at our disposal to bridge the gaps in care. Passing SB 221 is an important piece of the healthcare access puzzle, and I urge your support. Thank you, Senators Donate and Stone, for sponsoring this legislation.
Chair, there are no additional callers to provide testimony and support at this time.
Thank you so much. Let's go ahead and move on to opposition in Senate Bill 221. Is there anyone in Carson City, in Las Vegas, and virtually?
If you would like to provide testimony in opposition to SB 221, please press star 9 to take your place in the queue. Chair, there is no additional testimony at this time.
Thank you so much. And last but not least, is there anyone in neutral to Senate Bill 221? Seeing no one here in Carson City, anyone in Las Vegas, and virtually.
If you would like to testify in neutral for Senate Bill 221, please press star 9 now to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Ms. Logan, did you have any closing remarks? No, you're good. Thank you so much. Okay, at this time, we will go ahead and close the hearing on Senate Bill 221, and we will now move on to opening the bill hearing on Senate Bill 239, which establishes provisions governing the prescribing, dispensing, and administering of medication designed to end the life of a patient. With this, we have Senator Edgar Flores. So, Senator Flores, please proceed when you are ready, sir.
Chair? Mr. Chair, can I talk or no?
Good afternoon, Chair, Vice Chair, and esteemed members. I am Senator Edgar Flores, here to present Senate Bill 239. I represent Senate District 2, and I will be joined in my presentation by 3 additional individuals before we open up to questions. I'll have joining me Samantha Drad, Dr. Corey Carroll, and Sarah Mans, and I'll allow for them to properly introduce themselves. I will, however, say that they are experts in this area, and they will be providing a detailed breakdown of the bill, along with some additional anecdotal information of what's happening around the country, and then lastly, provide some detailed testimony as to what's happening presently in Nevada with some of our constituents. So I'd like to first start off this conversation, and following the direction of our chair, I understand we're limited with our time, so I'll try to be as brief as possible. But I think it's important to engage in this conversation in a meaningful way by saying first that I've had an opportunity to, in the course of the last 4 years, speak with a lot of folk who are passionately for and against this bill, and I am incredibly respectful of everybody's position. And I say that because I understand that there's some individuals that have very passionate beliefs that are grounded and rooted in religion, and I respect that 100%. I've had this conversation with my own family, and I've had to engage in that conversation for some time because it was important for me to get some buy-in from them as well. I will say that if I go back 6 years, I did not agree with this conversation. And namely, it was because I had not had an opportunity to have sat down and gone through a very personal encounter, emotional relationship, and that really put into focus and forced me to engage in this conversation in a way that I hadn't done before, because it was no longer anecdotal, but it was now something personal. And I share that story, and I shared it before. I remember in encountering this conversation with my family, and the question that was posed to us at that time was, how much suffering is too much? And when we talk about suffering, who is deciding that? Is it we, the family, forcing a human being to suffer up into the very last breath, to serve our own egotistical desire, to keep that individual for that additional second, regardless of how painful that moment may be for that individual? It was balancing that question with the second question, which is, are we engaging in the conversation of living versus dying? And I argue that it's not. You are not deciding between living and dying. You're deciding and controlling your own fate when you have a terminal illness and having the basic human opportunity and right to say, I am going to decide in this last breath how I go out. And that's incredibly important because I needed to get there and live through that experience to get to a place of comfort. I came in a very emotional stance in 2021. And I've changed that because I allowed myself to attend conferences on palliative care. I thought that was really important because I think I didn't have that component in my own presentation, in my own discourse when we talk about end of life. And when I went to these end of life symposiums, they call them, of all ways, they call them death symposiums, and they sound such a dramatic phrasing to it. But it was really important because I spoke to folk who they deal with palliative care every single day. And something that made me feel even more confident in engaging this conversation is they were talking about 3 key elements. Number one, they talked about the scenarios where individuals have a terminal illness, and in that terminal illness, take a whole host of medication to numb their pain. And they take so much medication to the point that they can no longer have a coherent conversation with their loved ones. They no longer know who they are. They no longer know who is around the room with them. They describe that scenario. They describe the scenario of individuals that take so much medication to numb pain that that medication itself ends up being what kills them. They talked about scenarios of individuals who suffer and are in so much pain that they are found in a bedroom with a gunshot to their head because they could not live another second with that suffering. And then they talked about something which, to me, is directly in line with what we're talking about today. They said, when you are at the very last second of your life, do you want to be in a cold room with doctors and nurses that you don't know, listening to sounds of machinery that are there just trying to keep you alive just a little bit longer, smells you don't recognize, food you don't know, and not surrounded by your loved ones? And they were talking about that palliative care has a responsibility of being compassionate, that it should not be that should be your last memory, that we need to make sure that folk are going back to their homes, that they're in their backyards, that they're surrounded by the people they love, that they have the food they care about, the smells they're familiar with, the voices they want, and also that they can remember that. And I realized at that moment that we were going to again engage in this conversation in 2023. But I thought that was important to engage in that because I want to debunk 3 things that we're going to hear today. One of the things that we're going to hear from folk is that we're choosing life versus death. And in my opinion, when you have a terminal illness and you are suffering every single second, you're not choosing between life and death. You're simply choosing how it is that you want to die. Number 2, palliative care has, in a very indirect way, been engaged in this conversation for a very long time. And you'll hear from Nevadans today who will talk about family members who just numbed pain to the point that they were no longer themselves, and that wasn't living anymore. And you're going to hear from individuals, and we'll debunk this notion that somehow doctors are going to be finding reasons to kill individuals and defining it and describing it as that, because that's not the case. And our experts will break that down in a very detailed manner to provide all the anecdotal Nevada and nationwide evidence that is out there to prove that that's what's happening. And lastly, I would just say to my own family, who I know endured in this conversation, that I am very grateful to them for having given me the opportunity on behalf of our family member who had to go through a very horrible situation to be able to present this bill again on their behalf. And with that, I'd like to pass it on to our co-presenters so they can walk us through the bill and provide some additional and very important information regarding this bill. Who would like to go first?
I'll go first.
Please. There you go.
There you go. Thank you so much for hearing this bill today. It is crucially important. Thank you, Senator Flores, for carrying this bill. I actually first met Senator Flores at the symposium he talked about that the City of Hope put on.
Name for your record, please.
Oh, that's important. My name is Samantha Trad. I am the National Director of Care Advocacy for Compassion and Choices Action Network and Compassion and Choices. I will be talking to you here today about the bill, and I can go ahead and start with my presentation. 1 in 5 Americans currently have access to this peaceful end-of-life care option. The first medical aid in dying law went into effect over 25 years ago. That's over half my life ago, and I know I look very young, but I'm actually in my 40s. So the good news is, we've had this law around for a really long time, and we have data from departments of health. So we have hard-based evidence to support the bill in front of you today. Currently, 11 jurisdictions have authorized medical aid in dying. As you can see on this map, the dark blue states have all authorized aid in dying. People can access the law there. The teal light blue states are considering legislation, and of course, the golden state, Nevada. What do I mean when I use the term medical aid in dying? You may know this as death with dignity. However, we don't call that death with dignity anymore, because a dignified death is up to the person. It doesn't have to be medical aid in dying. This is one of many end-of-life options that are available to people. It's also not euthanasia or assisted suicide. There's no assistance in it, and it is not suicide. In fact, it's in the bill language. This is very different from suicide. Medical aid in dying is a compassionate end-of-life option that a person can get if they are terminally ill with 6 months or less to live. And I'm going to go over the eligibility requirements for it in just a moment. There are 2 people that you're going to be hearing from today, 2 moms who live in Las Vegas. They're in the Las Vegas hearing room right now. So I just want to make sure that if you hear from anybody else today, these 2 women have terminal illnesses and they desperately want the option of medical aid in dying in Nevada. 3 out of 4 Nevadans support medical aid in dying. We live in an age where people can't agree on anything. But if you look at these statistics, they're amazing for the age we're living in. The majority of every single demographic, the majority of Democrats, Republicans, Catholics even, support the option of medical aid in dying. One thing we all have in common, even though we don't like to talk about it, is that we are all going to die. And people want to have the full range of end-of-life options available to them. Why is this such an incredibly important bill? Medical aid in dying is a widely supported end-of-life option that provides dying people with peace of mind and comfort during a difficult time, as we heard from Senator Flores. While only a small number of people will choose to use the option, to patients, it is a prime litmus test of person-directed care. It exemplifies a medical system that respects patients by allowing them to assert their values and priority as death approaches. So what is this bill? How does it work? It's a long bill, so I could nerd out with you all day and talk about this bill, but I'm going to be brief and go over the main things, and then I'll be open for questions. So the main eligibility requirements, in order to even be able to start the process to access this law, you have to be an adult, you have to be terminally ill with 6 months or less to live. That means this is for people who are imminently dying. You have to have mental capacity to make informed medical decisions. This is something you have to ask for again and again in the process, which I'll go over, and you have to fully understand what it is that you're asking for. You also have to have the ability to self-ingest the medication. Again, there is no assistance with this. And in fact, from all the data that we have from all the departments of health, from all the states that have this law over the years, we know that they have the same data point in each of the states. And that's about 1/3 of the people who go through this whole process to get the medication never actually take it. But just having it gives them a huge sense of relief to know that they have this option should their suffering become unbearable. So I'm going to talk about the steps from a patient perspective, and then I'm going to go over what the practitioners have to follow. So the steps to actually qualify for the prescription beyond the eligibility requirements. So you can't even start this process unless you have those eligibility requirements I just talked about. First, you have to make your very first initial verbal request. Then you have to wait a minimum of 15 days. Then you make a second verbal request. You make these requests to it's called the attending practitioner in the bill. This is the main prescribing practitioner. Then you also are you consult with the attending practitioner, and I'll talk about what they're going to go over with the patient. Then you also have to be evaluated by a second consulting practitioner. So you're going to see 2 different practitioners, one of them 2 times, 3 different visits. Then you also submit a written request signed by a qualified witness who must meet certain restrictions. And I can go over those later as well, if you would like. The attending practitioner duties. So the attending practitioner goes over the diagnosis and prognosis of the patient. They also talk to the patient about all available methods of treating or managing the terminal condition of the patient, including comfort care, hospice care, and pain control, and the risks and benefits of each method. This is informed decision-making, which is really important. I know I would want my doctor to go over every single thing available to me so I can make an informed decision. The risks and benefits of self-administering the medication, including the fact that death is the result. The attending practitioner refers the patient to a consulting practitioner. They inform the patient that there is no obligation to take the medication. In fact, the attending practitioner does this a couple times. The patient can decide not to take the medication at any time. As we've heard from the statistic, 1/3 of them don't take it. They instruct the patient against self-administering the medication in a public place. They refer the patient for comfort care, palliative care, hospice care, pain control, or other end-of-life care if requested or as clinically indicated. The consulting practitioner, this is the second practitioner that the dying person has to meet with. They confirm that the patient has requested a medication designed to end the life of the patient. They confirm the attending practitioner's determination considering whether or not the patient meets the requirements of the law. So again, the patient is 18 years of age, has been diagnosed with a terminal condition, has a prognosis of 6 months or less to live, has made an informed and voluntary decision to end their own life, is competent in making an informed medical decision, and is not requesting the medication because of coercion, deception, or undue influence. Other provisions of the law. Wills, contracts, insurance, and annuity policies are not affected. Medical aid in dying, again, is not considered suicide or assisted suicide. No physician, healthcare provider, or pharmacist is required to participate. Nobody has to take part in this if they don't want to. Healthcare providers receive civil and criminal immunity. Unused medication must be disposed of as required in Nevada. And again, this is a terminally ill patient, so they're going to have a lot of other medication, most likely, that is also going to have to be disposed of. Medical aid in dying, like I said, is optional. It's optional for the patient. It's optional for the doctors. There's no requirement to do medical aid in dying. Medical aid in dying improves end-of-life care. Study after study shows that medical aid in dying actually is palliative. It is part of palliative care. When people receive their medication, it helps ease the fear and worry. They're not forced to go down the trajectory of their terminal illness. The people who are requesting medical aid in dying, they do not want to die, but their terminal illness has determined that path for them. Medical aid in dying helps far more people than those who choose to use it. Like Senator Flores said, you know, we hear from people who tragically end their lives when they can't access the option of medical aid in dying. This really, it helps families, it helps the person have a peaceful end of life if that is what they choose and they qualify. So the data, like I said, we have so much data from all the years, from all the departments of health. Over 10,000 people have received prescriptions for medical aid in dying. This is from 1997 to the end of 2021, we have data for. This represents far less than 1% of the people who die in each jurisdiction. Very few people actually choose the option of medical aid in dying, but it's really important that they have that choice. Over 1/3 of people who went through the entire process, like I said, never take it. They have peace of mind from simply knowing that if their suffering became too great, they would have the option. The vast majority of terminally ill people who used medical aid in dying, more than 87%, received hospice services at the time of their deaths, according to the annual reports for which this data is available. Terminal cancer accounts for the vast majority of qualifying diagnosis, with neurodegenerative diseases such as ALS or Huntington's disease following as the second leading diagnosis. And I got to tell you, my Lyft driver on the way here told me that she has Huntington's disease. She asked me what I do. We had a conversation. She said that one of her biggest fears was that she was going to have to go to California to access the law. She knew all about medical aid in dying, which I wasn't surprised about. A lot of people know about this law. She has Huntington's disease, and she wanted to come here to testify today, but she couldn't. She lives in Sparks, Nevada, and she was so grateful that we were here today presenting this bill, and she hopes so much that it passes. We cannot wait any longer. We need to pass it for people like Julia. And finally, just over 90% of people who used medical aid in dying are able to die at home, which is where most Americans would prefer to die, according to various studies. In over 25 years, there has never been a substantiated incidence of coercion or abuse. Again, this is not a new bill. It's not a new law. Countless people have had peace of mind by having the availability of this option. Thank you so much for considering this important bill.
Thank you so much. At this time, we will go ahead and pivot it to questions from the committee members. So just for the committee members, I will, just in the interest of time, you can have one question and one follow-up, but just, we can take most of the questions offline as well, but I will give everyone the opportunity to do so if they want to. So Senator Titus, I presume you have questions? Go for it.
With a long list of questions, it's going to be hard. I can stick right straight to bills, very specific, non-emotional. Just looking at the bill, first off, I have to make a comment that your Huntington's chorea patient wouldn't be eligible for this medication because I've taken care of many Huntington chorea patients that have lived a decade plus with the diagnosis. So within the scope of this bill, that's not a 6 months diagnosis. Just to be clear, and you shouldn't. Hopefully, you informed her of that.
I actually did. I said you have
very
to have
good.
a 6 months.
That's not a question. That wasn't a
Yes,
question.
that wasn't a question.
That's not my own question. Okay, now question. All right.
Your name for the record too, by the way, when you present.
Samantha Trad.
Thank you
So
so much.
I do have a lot of questions, but I respect you, Mr. Chair, and I think I'll start, and then I can, with the rest on offline. Obviously, we do have a limited time, so I respect that. So just looking at the bill itself, in Nevada, at Section 4 of this bill, line number 3, signing a death certificate. I have signed multiple death certificates in our state. We do them online now. And there's multiple levels. What was the immediate cause of death? And the majority of the time, it's a respiratory arrest, a hemorrhage, a heart attack, something along those lines is the immediate cause of death. And then they say other things affecting this, whether it's diabetes, heart disease, et cetera. And there might be a litany of them, 4 or 5 lines, actually. So under this bill, we are obligated to say what their primary diagnosis was. Well, that's counter to what typically we would sign the death certificate is. And with all the same questions, the same section, it also allows a physician assistant to sign this. Now, in the state of Nevada, we currently, and I asked our legal before I came today for clarification on this, in the state of Nevada, In 2017, we expanded who could sign a death certificate under SB 227, and that gave the authority to nurse practitioners, but not to physician assistants. So this bill would dramatically change that. So you're expanding the scope of a physician assistant to now assign a death certificate, and you're mandating that I, as a physician, if I was the one attending this person, falsify the record and say that they died from something that they didn't die from, because that disease may have gone on for 6 months or so. So could you kind of clarify those two
Yeah.
things for me, please?
So, Senator Titus, we want to amend. You want to? Can I take that?
Sure,
'Cause
yeah.
Yeah. Go ahead, sir. And name.
Yeah. Sarah Mance for the record. Dr. Titus, thank you for your question. We actually reviewed this a little bit ago, and the point that you raised about physician assistants not being able to document a death in the code is absolutely correct, and that was a drafting error, and we do plan to correct throughout. The other point that you've raised, which is the death certificate question, I think the most important thing is to think about, what is the purpose of a death certificate? Well, it's to legally document the person died, right? It's to indicate the cause of death so that epidemiology can study and prevent disease. So that's what that's for. So the mechanism of death, if someone discontinued dialysis, you wouldn't say that their mechanism, that their cause of death was they discontinued dialysis. You would say they had renal failure. Similarly, what we're asking to do here is to have the death certificate reflect the underlying cause that is the same terminal illness that makes the patient eligible to even ask for this in the first place. And the reason for that is the legal aspects of that Ms. Trad raised about making sure that people's insurance can pay off, and so to protect the patient. But it's also to protect the physician. This is extremely important, because if we allow for discretion about describing this practice that is the patient self-administering a medication given for this purpose as suicide or potentially as homicide, that opens up a realm of problems in the criminal realm where we don't want to go. So that is the other reason, is it's, and life insurance, a lot of it, suicide disclaimer, but also it's to protect the physician, to make sure that they're really covered with this practice. So that's, I hope that's, yeah.
Thank you, Mr. Chair, for your indulgence. Along that same line of questioning, you mentioned the coroner or the coroner's case, and part of this bill also says you can't investigate that. So how do we know it's not a homicide then if we're not able to actually follow the accurate chain of events?
Senator Titus, Sarah Mance for the record, Mr. Chair. That is an excellent question, and we are working with attorneys at the Association of Counties to determine how we can rework this language so that their concerns, which are the same ones you've just raised, can be covered.
And the only request that I would have is when you make that determination to please communicate that to the committee members, because I think it's important for us to make sure that clarification if the bill moves on. Thank you. Senator Stone.
Thank you, Mr. Chair. First, I want to commend Senator Flores for bringing forward a bill like this. Obviously, we want to ease suffering from those that have been given the horrific diagnosis of a terminal illness. And there are two things that come to mind that scare patients. One is primarily, are they going to be in pain, and are they going to suffer? And two, are they going to be a burden to their family? So as a pharmacist that I got my doctorate and I specialized in pain control. I dealt with hospices. I actually started a hospice in California. When you have the armamentarium that we do, we have morphine, of course. We have Dilaudid that's 7 times more potent. We have fentanyl that's 100 times more potent. We got sufentanil that's 1,000 times more potent. And you're absolutely right. People want to die in their homes, and they want to be surrounded by their loved ones. I'm a big fan of palliative care. I've seen it work, and I want to ease the suffering. And we shouldn't use financial resources as a reason why people should take their lives because they don't want to be a financial burden to their family. One more thing I would just like to say, and with all due respects to our honorable chair, this is a very complicated bill. And as a healthcare professional, being limited to one question, when I have so many questions, and we have so many people that want to testify on this bill that can't even go to the Grant Sawyer building because President Biden's in town and they've closed all the roads down. I just feel like we're not vetting the bill as carefully and as comprehensively as we should. So with that said, I'm going to honor the one question, but I have many. But the one that I want to ask today is that on page 2, line 18, it says that you have to have a witness that has to accompany the letter that the person says, I want to have end-of-life therapy. Can that witness be a family member and an heir to the estate of the future deceased?
Excellent question, Senator Stone.
Your mic, please.
Samantha Trad, for the record. Thank you, Senator Stone. So there's 2 qualified witnesses that are required for the written request. And the witness cannot be related to the patient by blood, marriage, or adoption. One witness entitled to any portion of the estate of the patient upon death under will or by operation of the law, an owner, operator, or employee of a healthcare facility where the patient is receiving treatment or is a resident, the attending practitioner, or an interpreter for the patient. And I apologize, I said 2 witnesses. This bill has been improved. We've learned from the other states. So there's 1 qualified witness, and they cannot be related to the patient. Do you have the section?
I don't.
Okay, I can find the section, but this is from the bill language. Actually, I have it right here. So it is section 24, part B. It's on page 10 of the bill.
Senator Stone, did you have a follow-up question?
My only follow-up, and thank you for clarifying that. I think that's a very important protection. You mentioned, which I thought was stunning, is you said that there was no issues of coercion since this idea of patient-assisted suicide was enacted over 25 years ago.
Mm-hmm.
But I wish I had more time because during my presentation in California on the same bill, I brought up many examples of coercion that were, I think, prosecuted either by the state of Oregon or the state of Washington. I can't remember which one. So I'm going to try to drum that up, and I'll give it to the chair to present to you. But I think there were cases of coercion, and I hope that we can. That's why we need some vetting of this bill so that we can have an honest debate and make sure that we're getting our facts straight so that we understand what we are putting into Nevada statutes. So anyway, I appreciate you being here.
Yeah.
Can you go
Samantha
ahead?
Trad, Senator Stone, yeah, thank you. So there's never been a substantiated incident of coercion or abuse. So I would love to see that. And also, California's bill passed 8 years ago. So now we have about 7 years of data from California as well that also is evidence-based that shows that this is a good bill that has been tested. And has all of the evidence to support it. We also have peer-reviewed studies that I can talk about pain management, but I can wait if there's a specific question for that. It's been alluded to, so.
I think if you can refer those documents to the committee members, that would be great as follow-up.
Absolutely.
Thank you so much. Vice Chair Nguyen.
Thank you. I don't really have a question, just more of a comment. I know that we have such a limited time here being a part-time legislature, and I know that this is Senator Stone's first time kind of going through the Nevada legislative process. And I think there are thousands of bills that are introduced, and I think even in the 81st session, or 80th session, there were, I think, 539 of those that ultimately made it to the governor's desk. And so we do have limited time, but I do appreciate, and I know that I have spoken with Senator Flores, and I'm sure the members up here on the dais have also had that they are truly willing to work to make sure that this bill, and they are listening, and I know they are taking the comments from the committee members as well as the testimony and support and opposition, and those questions that are proposed during that public comment period, in trying to make this the best bill possible. So more of a comment than anything, but thank you for that.
Thank you so much. That concludes the round of questions. I do have one for Senator Flores before we go to testimony. If you want to switch in. Senator Flores, do you have can you give us just really quickly, how many times has this bill been introduced, if you have that on the top of your mind, and have you had a hearing before?
Yeah, no, and thank you for that, Senator Flores. For the record, we have had the support and opposition now at least 5 different times here before the Nevada State Legislature. In fact, it's moved out of the Senate, it's moved out of the Assembly. It's been in both houses, and we've done ample vetting. And at one point, I wasn't sure if I supported this bill. And I've been here long enough, and I've had this conversation for so many years now that I've had an opportunity to shift even my own position, only to make the point that there are folk that are going to be in opposition today that have been opposition 4 times already. So I am respectful to our senator's comments, and I understand that you haven't had an opportunity to be here that long, but this conversation has been going on for many years, not just 30 minutes, but many years in this body.
Thank you so much. All right, at this time, we will go ahead and move on to testimony in support, opposition, and neutral. So in the interest of time, we will allocate 15 minutes to each section. If we have additional time after that, we can go back and review the process, but we want to make sure that everyone top line understands 15 minutes for each section. As a recommendation, you have 2 minutes. Please do not go over those 2-minute marks. We encourage, if there are additional comments, you can always say ditto. You can refrain from documenting the full 2 minutes, and we please encourage everyone, specifically on this personal issue, that if you do have sentiments that aren't covered in the 2 minutes, please communicate them to the committee staff so that we can accurately reflect it. We'll start here in Las Vegas, so please proceed.
Good afternoon, committee. My name is RJ Erickson. Thank you for having me here today. I wish I was here under better circumstances. I am the proud son of Dr. John Marshall Erickson, former OBGYN in Reno, Nevada, who is a strong advocate of this bill. And tragically, he lost his life due to stage 4 lung cancer 2 months ago to the day. I am here to not only speak on his behalf in advocating this bill, but also in my personal experience in seeing his end-of-life journey shortly after the new year. He had asked my stepmother and me, graciously, to begin this journey. And as selfishly as we would have wanted to hold on to him every minute we possibly could, we didn't want him to see him suffer and struggle and lose his dignity and really go through a torturous path. And so we began the end-of-life journey with hospice. And even though the hospice nurse was very gracious and empathetic towards the situation, the expectations that were set and laid out for us was nothing that we were expecting, and was certainly nothing that came into fruition. During this end-of-life journey, I was personally responsible for mixing his methadone and morphine. I was slowly killing my father. And over the 5-day period before he finally went into a medicine-induced coma, there were episodes of hysteria, delusionness, and the breaking point was after day 4, when he asked his hospice nurse, under this delusion, this state of not being fully aware and conscious, if they had found a cure for his stage 4 lung cancer. It was not what I was expecting to have happen. He wanted a peaceful and painless passing. And for loved ones, watching their other loved one go through this is not something anybody should have to endure. And he, being a physician himself, he would have loved a more peaceful passing to save his dignity. My last comment.
Thank you, sir, for your comment. We have to move on to the next one. So if you can please submit that in writing, we would greatly appreciate it. And thank you for sharing that. Please proceed.
Do you want me to go next? Chairman, member of the committee, my name is Dr. Corey Carroll. I am a board-certified family physician in private practice in Fort Collins, Colorado. As of January of last year, I also became the part-time National Medical Director for Compassionate Choices, and I'm here supporting Senate Bill 239. I am one of the physicians, the attending physicians, that will prescribe this medication. Over the 7 years since the law passed in Colorado, I have personally helped 12 patients control their end. I've also had the opportunity to tend each death. I do not have time to go into all the individual stories, but I will tell you that in my experience, as well as the stories I've heard from my colleagues, this compassionate medical intervention is not inconsistent with the practice of medicine, nor is it detrimental to the physician-patient relationship. I've had situations like we've just heard. Physicians have been in the hospital and watched their patients die. That's not humane, especially if there's another way out. I want to also report that in June of 2019, the American Medical Association adopted a new policy. For the first time, the AMA affirmed that physicians can provide medical aid in dying according to the dictates of their conscience without violating their professional obligations. The preceding year, my academy, the Academy of Family Practice, changed their policy to engage neutrality on medical aid in dying. Despite multiple attempts to reverse that body's decision in the subsequent years, that policy remains. Polling of physicians in Colorado regarding medical aid in dying showed that 56% of the members were in favor, while 35% were opposed. Last month, your colleague, Dr. David Ordenlaker, and I presented to the Nevada family physicians at their annual meeting in Lake Tahoe. Physicians were very receptive to the presentations, and medical students and residents took that to their institutions for more discussion. The previous week, I presented to the Nevada Medical Society.
Thank you so much for your comment. Unfortunately, we have to move on to the next one. Please submit your comment and testimony. To the man in the middle, please.
Good afternoon, committee members. My name is Claire Johnson. I'm an ER physician and live in Reno with my husband and daughter. As an ER doctor, I see a great number of patients suffer at the end of their lives. I see patients lose their ability to eat as stomach cancer takes over their bodies. I have seen men who are 6'2", weighing only 130 pounds at the end of chemotherapy. I'm relieved to know that we in Nevada are once again considering a bill that would honor the options of terminally ill people to decide how and when they die when death is inevitable. It has become evident to me, with great medical advances, we have also created great suffering. We live longer, but often not better. I believe it is our moral imperative as a society to give options that alleviate this suffering. We have embraced hospice. We must go a step further by passing this bill. There's a common misconception that people die of natural causes in the last 6 months and often go peacefully. That's untrue. Some of us will die after days of dehydration and weeks of starvation as we lose our ability to swallow. That is how my dad died in 2020. A coworker in California recently lost a family member after a battle with metastatic cancer. In the end, she couldn't eat and was bedbound. California fortunately had authorized medical aid in dying. She then died in the comfort of her own home with her loved ones by her side. I ask you to set aside your personal beliefs and consider passing this bill. We owe it to the diverse population of Nevada to provide diverse options at the end of life. Thank you.
Thank you so much. Let's go to Las Vegas. We'll start from the right-hand side.
Good afternoon, Chairman and members of Health and Human Services Committee. My name is Hannah Olivas. This is my third time speaking on the medical aid and dying bill. I am currently a patient here in Las Vegas, Nevada. I was diagnosed in 2017 with a very rare cancer called multiple myeloma. I'm a mother of 5 children, ages 10 to 30, and this is a conversation that I've had with my entire family since diagnosis. And the incurable disease that I have, I was told 5 years tops. I surpassed that. But I can truly tell you that I have watched several other people with similar disease as mine utilize the bill in other states. And I can tell you that since I've been diagnosed, I have to travel outside of Nevada to receive proper medical care, first and foremost, because what I have is complex. I've had open conversations with my family, my friends, my children, my husband, who all support the decision that I would use medical aid in dying. And what saddens me the most, and what I feel is the most important part about this bill, is that this is such a personal decision and should be a personal decision between the patient, her family, and doctors. It disappoints me that this is my third time, and I'm currently going through treatment, that I am coming here today again to plead with people who don't really understand a terminal diagnosis. Because if you did, you would hear what we're saying. This is not a suicide bill. This is us as a patient asking perfect strangers to hear our voices and understand what we're saying. And that is, when that time comes, if we've done everything humanly possible to fight the disease that we fight, and doctors are telling us that there is nothing left that we can do, then we should be allowed to utilize
Thank you
this
so
bill
much, ma'am,
here
for your
in
comment.
Nevada.
If you can please submit your story in to the committee secretary, that'd be greatly appreciated. We have to move on to the next one. Thank you.
Hello, my name is Dan Diaz, and I am Brittany Menard's husband. My wife died on November 1st, 2014. She was only 29 years old. Brittany experienced a gentle dying process only because of the option of medical aid in dying. Yes, my wife utilized the very program that we are here discussing today. I am testifying in support of SB 239. Brittany's case received significant media attention because we had to move from our home in California to Portland, Oregon, so that she could access Oregon's law. Had we stayed in California at that time, that brain tumor would have essentially tortured her to death. So in contrast to the hypotheticals and many times the false narratives that the opponents try to attach to medical aid in dying, I've actually lived this experience. To be clear, a terminally ill individual that applies for this option is not giving up. They are not suicidal, and they are not deciding between living and dying. The option of living is no longer on the table. The opponents seem to ignore that. A terminally ill Nevadan that is in Brittany's predicament, the only option they have is between two different methods of dying. One is gentle, the other can be filled with unrelenting suffering. Brittany felt incredibly protected throughout the entire process of applying for this option because getting through this process is not easy. Those safeguards are real. I want to emphasize the importance of palliative and hospice care at end of life. Brittany's team played a huge role in helping keep her comfortable, but modern medicine cannot control pain and suffering in all cases, period. Any assertion by anyone that they can control suffering in 100% of the cases, that is patently false. Full stop. I can line up physicians, nurses, hospice care workers to refute such an arrogant claim. The people of Nevada deserve better than what Brittany had to endure. No one in Nevada should have to ever leave their home and move to another state in order to ensure a gentle dying process. Thank you.
Thank you so much. Next person, please.
Hello, my name is Linda Brooks Bracey. I'm 57 years old and I live in Las Vegas. I prefer not to die at this particular time, but unfortunately, even though I consider my age quite young, my diagnosis says differently. I have been diagnosed with metastatic pancreatic cancer. My doctors, we have done all that we can do. I've been through numerous rounds of chemo, surgery, everything that is left to be done, and I am terminal. I very much believe that people in Nevada want and need SB 239. This bill may not become law in time for me, but I believe it should become law for those in need, and there are many people in Nevada in need right now. I am a strong believer in the circle of life. I'm a believer in God. I know that it's my timing, but I don't think I or my family should have to see me suffer. I'm a strong believer in hospice and palliative care, which I'm on currently. They do a wonderful job. I personally believe these people should be Person of the Year. What they see and what they have to go through as physicians in palliative care and in hospice and nurses is unbelievable, and they do a phenomenal job. But as others have stated, they cannot do everything, and then they cannot guarantee a lack of suffering. Many people say, oh, you're interested in this bill now because you are ill. The reality is, I became a widow very young. My husband passed away at 38 of leukemia, and myself and my kids watched him suffer close to 20 years ago, and not much has changed here in Nevada. He had wonderful medical care in Nevada. He had wonderful hospice care. Nonetheless, we watched a young man pass away in great pain because there was no other options. Most of us here in Nevada, as in other states, just want all the choices that are available. This bill, SB 239, gives us those options if we agree.
Thank you so
and
much,
we can pass
ma'am, for
this
your
bill.
time. We're going to have to move on to the next one. We'll start from this.
Thank you.
Good afternoon, honorable members of the Senate Health and Human Services Committee. My name is Kim Mazeras. I am a retired executive from the utility industry, having lived in northern Nevada for over 40 years. My husband, Steve, loved life. He was a determined, intelligent, and caring man, a devoted father and grandfather, a veteran who late in life went to law school, spending the best days of his career at the Washoe County District Attorney's Office. Our wonderful marriage of 30 years took a drastic turn in 2017. Steve was in his 50s when doctors initially diagnosed him with COPD. He spent years without disruptive symptoms until the spring of 2017, when he had a life-threatening exacerbation event. Steve's best hope was a lung transplant, which he opted for. He did well for a year, but something kicked off chronic rejection, and it was continually harder for him to breathe. But he continued treatments that could stop the rejection. During this entire process, Steve wanted the option to decide when enough was enough. We had numerous conversations about his end-of-life wishes, including a potential move to Oregon to access the state's Death with Dignity Act. I was angry about the idea of uprooting ourselves to establish residency in a state where we have no family, a place that wasn't home for either of us. I don't know if Steve would have ultimately used the medication to die peacefully, but simply having it as an alternative in hand would have eased both of our minds and lessened the stress and fear of his pain and suffering. Steve's last 24 hours were horrific. He was in a tremendous amount of pain, and I scrambled to enroll him in hospice. His pain was unbearable without a more serious opioid. They let us know they could apply a fentanyl patch, but it was likely that he may not wake up once it was applied. Steve understood and agreed to move forward. Less than 5 hours later, my husband of 30 years took his last breath on June 9th, 2020. Honorable legislators, I urge you to support the End-of-Life Options Act so terminally ill Nevadans will have the option to shorten their suffering at the end of their lives. Thank you.
Thank you so much. That concludes our support testimony. We have reached the 15-minute mark. Considering that we have to move on to downstairs, we will go ahead and take a recess. When we come back from the State of Judiciary, we will continue with 15 minutes of opposition and then 15 minutes of neutral. So just as heads up for everyone to keep an eye on everything. But at this point, we will go ahead. Senator Flores.
Thank you, Senator Edgar Flores. For the record, just for the sake of fairness to the opposition, just in case some of them have to leave, could we ask that those in opposition rise so we can acknowledge them? I don't want them to feel that that was intentional. They
Sure.
should get an opportunity to be recognized.
Thank you so much. So we'll start first. If there are folks in the room that would like to voice their support for the bill but weren't able to testify, to please rise at this time. Thank you so much. And for the folks that are here in opposition, and then any folks in neutral. Thank you so much. Thank you so much, Senator Flores. At this time, we will go ahead and recess.
Senator Tenate, I'm just wondering if the people that stood, if they have written testimony, if they couldn't submit it at the desk, for the record.
That's correct. So if you are unable to participate today and you won't be able to come back, you can always provide your testimony to the committee secretary in case if you have to leave. So thank you so much for joining us. We'll be back. Welcome back to Senate HHS. We will continue off where we left off, which is we were conducting the hearing on Senate Bill 239, which establishes provisions governing the prescribing, dispensing, and administering of medication designed to end the life of a patient. As we reiterated, for transparency, we will continue our testimony. We left off, and so we're starting off today in this part of the hearing with opposition to Senate Bill 239. Just as we did for support, we will allocate 15 minutes, and then we ask respondents to please remain within the 2-minute period. And if you're not able to meet those time requirements, of course, you can always submit your testimony to the committee secretary. So, Mr. Santos, please begin.
Thank you, Chairman Donate. For the record, my name is Herb Santos, Jr. I was born and raised in Nevada and have raised my family in Reno. I'm here to oppose SB 239 because I respectfully submit that this bill is bad for Nevada and has the potential to harm the most vulnerable in our great state. What at first glance may appear to be an act of compassion, in reality, it is really a pathway to a system which would expand assisted suicide to the disabled and to vulnerable people with non-terminal debilitating conditions. In addition, insurance companies would have free rein to manipulate the rules by denying life-prolonging and pain-reducing medications and directing people to the cheapest choice, a prescription for death. You see, I witness almost every day in my workers' compensation practice insurers denying treatment and pain medication. Insurers use out-of-state doctors to deny treatment, which in turn delays recovery, and in some folks, makes them give up and go away. It's all about money over people, and in this case, profits over people. Assisted suicide is the perfect vehicle for insurance companies to deny or delay treatment and pain medications and pocket millions of dollars. When delays and denials happen, folks simply give up. There is no protection for the multitudes of Nevadas that this could affect. What is equally alarming is that any safeguard in this bill to protect the vulnerable is hollow. The proponents advance safeguards while at the same time lawsuits are filed and proposed legislation is advanced in the few states where assisted suicide is illegal to remove the very same safeguards, claiming now that there are barriers that must be removed. Currently, they are seeking to reduce these barriers by shortening the waiting periods, supporting mail-order delivery of death drugs, expanding who can make the request, and eliminating self-administration of the death drugs. Once a suicide bill has become law, removing the safeguards is the next order of business. I respectfully implore you to not let them get their foot in the door. This bill is bad for all Nevadans. I respectfully ask that you reject this bill and vote no on SB 239. Thank you.
Hello. For the record, my name is Dr. Kirk Bronander. I am an internal medicine physician, board certified in practice hospital medicine. I've practiced here for over 20 years. SB 239 is flawed legislation. It allows a PA, nurse practitioner or doctor, to prescribe a lethal medication to a patient to end their lives when they have a terminal condition. This is essentially when any healthcare professional believes they will die within 6 months. The prognostication of when a person will live 6 months with a terminal illness is subjective. It is very difficult to know how long someone will live in the final weeks, days, or months of an illness. Study after study done on the prognostication of illness has proven this. My own father was diagnosed with a glioblastoma and given 6 months to live and lived for almost 4 years, in 1994, that is. A misdiagnosis coupled with poor prognostication results in a patient getting a lethal prescription when they could have years of good quality life left to live. This law could also create a cottage industry of advocates referring patients to medical-assisted suicide clinics that would take care of the second signature or other safeguards. This law does not require a patient to be a Nevada resident, meaning people will travel here for healthcare-assisted suicide tourism from other states. Oregon did away with their residency requirement this year due to a lawsuit, and they are now experiencing this. The proponents always argue that it works in other states. One of the major flaws is that we don't know how it's working because healthcare privacy laws prevent us from questioning anything. The prescribing doctors are unknown. The circumstances and the patient's names are completely unknown. The only thing we know is in a small document that's produced once a year. And even in that document, we know some things that are alarming. For example, in 2022 in Oregon, there were 431 prescriptions written for lethal medications and 278 deaths. And this was mentioned in the testimony. That means there's 153
Thank you so much for your
prescriptions.
comment, sir. Unfortunately, we have to move on to the next comment, and you can submit your comment
Okay.
and testimony.
Thank
Thank
you.
you so much. Ma'am, please proceed.
Hi, my name is this on? Okay. Hi, my name's Kathleen Rossi. I'm a retired RN who's worked in critical care and taken care of hundreds of dying patients in my 36-year career. I'm proud of the fact that I've helped people die well. It's just for the note, it's disconcerting for me that this hearing was added to the agenda so with only hours for us, the opponents, to get here. And I would know the disabled community was not able to show up today, so I would please ask that you let them speak to you privately when they can. I actually left the bedside of my sister, who is dying of a brain tumor as I speak. My sister was given 18 months to live 14 years ago. This is another millionth example of doctors getting the prognosis of timing wrong. The fact is, I believe when we are really sure that a person has entered the dying process, we can be really good at taking care of them. And assisted suicide is not even necessary for what these people are claiming it's needed for. What is needed is better funding for hospice and palliative care, and not this option which will actually prey on vulnerable victims. Assisted suicide laws are based on the desire for patient autonomy, which, granted, this is a high medical priority, but it is never the only one. Laws should be based on the common good and the effects of society as a whole. I beg you as legislatures to look at the unintended consequences of these laws that are really no longer conjecture at this point. The slippery slope is occurring in Canada and Europe, where euthanizing, not assisting death, is taking place, and not for just simple things, but mental illness and someone who couldn't get the care that was due to them. Ethical boundaries in the medical profession have existed since ancient times for a reason. The power you think you are creating yourself with this law, you are actually giving away to physicians, and even in this bill, less educated PAs. In fact, for the push for PAs to do this should be a huge red flag. I also want you to listen to the disabled community.
Thank you so much, ma'am, for your comment. Unfortunately, we have to move on to the next one. Please proceed.
Good evening. My name is Teresa DeGraffenreid. I'm a citizen lobbyist testifying on behalf of myself and all vulnerable citizens of Nevada that in the future may be faced with a decision like one that you're proposing. I'm passionate about decreasing suffering and have traveled as a missionary to Haiti to work side by side with missionaries of the poor to help alleviate suffering of the mentally and physically vulnerable people of Haiti, basically the kind of people who have a right to suicide themselves. Suicide is the act of intentionally causing one's own death. This is suicide. I believe allowing doctors and others who are even less qualified to give lethal prescriptions to their terminally ill patients is just dangerous for Nevada. SB 239 is dangerous for medical personnel. It wrongly assumes that medical personnel are the best moral agents. They are not. It takes no great skill and very little time to write a lethal prescription, but it takes consummate skill and lots of effort to provide good end-of-life care. Allowing lethal prescriptions also gives the physicians too much power. They would be judge, jury, and assistant executioner in the end-of-life decisions. The power is not in the patient's hands. This is not about giving patients the right to die, but giving physicians the right to kill them. SB 239 is dangerous for families. Could you imagine visiting your parent in a nursing home and finding their bed empty? When you ask, you find out that their physician or other medical personnel gave them a lethal prescription and they took it without saying anything to you. I know how I would feel, guilty. How did I not see the signs? Angry. How could their doctor do this without bringing me into the discussion? And I would feel profound sadness. The proposed law does not require family notification. SB 239 is also dangerous for patients. The right to die will soon become the duty to die. My father-in-law, Richard, was in the hospital. He was very ill, and knowing that he becoming a financial burden to his wife, there were times when he said to her, "You should take me out." We refused to give up hope that he would get better and come home.
Thank you so much, ma'am, but unfortunately we have to move on to the next comment in the interest
Thank
of
you.
time. Please proceed. Your mic, please.
Barrycole,
Thank you so much. This bill is flawed for two major legal reasons that I can already detect. One, it's an ADA violation. What do you do with the man with locked-in syndrome? What do you do with the man with a cervical cord injury? How does he or she self-administer? It's already discriminatory on its face. Secondly, you've mistaken competence for capacity. As a psychiatrist, I determine capacity. I have no say about competence. That's assumed to exist until a judge takes it away from someone. I'm an AMA EPIC trainer. I was trained in 1999 to train other physicians in end-of-life care. What happened to that initiative of the AMA? I've taught more AMA classes in the first 3 years than the AMA itself did. I did that through the American Academy of Pain Management, which I founded, along with the Academy of Hospice Physicians, and I've cared for over 300 people to death, and I can assure you not one of them ever asked me to kill them. I've had a couple of family members ask, how can we speed this up? That's a different discussion, but not the patients themselves. They died comfortably. With boards in psychiatry, boards in pain management, and a residency in neurology, I can usually keep people well pain controlled. We've gotten some better techniques through the years, blocks, interventional procedures. I understand what's motivating this. 25 years ago is when we started. Let me remind you, 2,500 years ago, we wrote the Hippocratic Oath. And the first thing I swore when I took that oath, I would not give people poison. That's a pretty clear, bright line for me. Maybe for other healthcare professionals, not for me. Thanks.
Ladies and gentlemen, Melissa Clement, Nevada Right to Life for the record. I'm sitting here looking at the screen that you see right there, and the last thing it says is, thank you for considering this important bill. Can you actually say that you are considering this important bill? Because let me tell you what happened today. I woke up at 7:15, took a shower. Before I got in the shower, I noticed that there was nothing on HHS agenda today. And then I got out of the shower. Fortunately, I got my PLT report, which is the only reason why anyone is here today, because that was the first time anybody heard that this very important bill was being heard. Now, you know what you don't see behind me? You see no disabled people. They are one of the communities that are most impacted by this, and they are always at this hearing. And I called them today. And they said, what are you talking about? We need 48 hours. Whatever happened to accommodation? On your own agenda, it says you give accommodation. Now, I'd also like to point out that when I found out that we had this testimony, we were only going to have a bit of time, I talked to the committee secretary, and I asked her, can we turn in additional testimony? Because I knew we would get maybe 15 minutes as opposed to what the folks on the other side got. She said, absolutely not. Nothing will be accepted after the end of this meeting. So I would ask the chair, please allow people to turn in additional after the time.
I can reset your time if you want to talk about the policy of this proposal, but I would prefer that you would.
I'll talk about the policy.
Thank you so much.
And thank you, Senator. I appreciate that. So there are a number of very problematic concerns that will impact this, impact our state. Number one, the fact that there's no physician requirement alone, and then you add to that there is no residency. There is no established relationship between a patient and a doctor or anything like that. There's no screening for depression. Now, if anybody has ever walked the walk with a loved one like I have many times, depression is something that they deal with. My dad was at the age of 88, was given a 3-month diagnosis of terminal cancer. 10 years later, he passed away after sitting on the floor of the assembly. And it was the greatest honor that he ever had. And he also got to teach my youngest son how to cheat at cards. Imagine if my son wouldn't know how. I mean, in the state of Nevada. What I'm telling you is that doctors do not know when the end is coming. And no one here is considering the very real issue with depression. And suicide is something we have far too much of in the state. So I'm asking you, please vote no on SB 239. Thank you very much, Chair.
Thank you so much. Before we proceed, I did stop the clock very quickly. in no respect for this particular part of the opposition for testimony, we are solely focusing on the policy options of this bill. And I would ask the community, if you are going to be talking in opposition or in neutral as we go through this process, that you refrain from the process or the commitments that you have spoken to my staff, and just refrain and just focus on the sole policy of this proposal. And that is something that we will ask from everyone on all sides of this bill. Please proceed.
Mr. Chairman, members of the committee, I've been a citizen lobbyist in this building for 50 years, every session, and I am appalled at the way that the short notice was given to us. The arguments for assisted suicide are equally arguments for euthanasia. Supreme Court Justice Neil Gorsuch points out that some contemporary activists fault the movement for not being honest about where the arguments are leading. The logic of assisted suicide leads to euthanasia because if compassion demands that some patients be helped to kill themselves, it makes little sense to claim that only those who are capable of self-administering the deadly drugs be given this option. Should not those who are too disabled to kill themselves and end their suffering ended by legal injection? And what of those who are too disabled to request that their suffering be ended, such as infants or the demented? Why should they be denied the benefit of a hastened death? Does not compassion provide an even more compelling reason for a doctor to provide the release from suffering and indignation? This evidence from the Netherlands, which has over 30 years' experience, suggests that safeguards to ensure effective control have proved inadequate. In the Netherlands, several official government-sponsored surveys have disclosed that both that in the thousands of cases, doctors have intentionally administered lethal injections to patients without request, and that in thousands of cases, they have failed to report these incidents to the authorities. You are opening a door which cannot be closed, and you will jeopardize those who are helpless, those who are disabled, and those who are depressed and can't defend themselves. Please vote no on this bill, and please, we request that in the future we be given more notice. Thank you.
And for the record, that was Ms. Hanson. So.
Oh, I'm sorry. I forgot. Janine Hanson, State President, Nevada Families for Freedom.
Thank you, ma'am.
I appreciate you allowing me to say that.
You're good.
How many times have I done it and I forget? See, I'm getting demented.
We are good. So we have reached to the last one, so please proceed.
Good afternoon. My name is Joy Trushinsky. I'm a non-paid lobbyist and a Navy veteran. I live in Carson City. I oppose SB 239 as it could be a slippery slope and lead to murder of someone with dementia, depression, or the physically disabled. It seems to me insurance companies and the government support assisted suicide to save money by pushing lethal drugs which are less expensive than treatment. It is money over people. Additionally, the real cause of death, assisted suicide, is not put on the death certificate, which will obscure the number of deaths by assisted suicide. Please vote no on SB 239 to protect the elderly, the depressed, disabled, and vulnerable. Thank you for your time.
Thank you so much. That concludes our rounds of opposition. We will now go ahead and offer the same 15-minute allocation for neutral on this bill. So if anyone in Carson City would like to testify in neutral on this bill, please proceed to the podium. We'll start first in Carson City, and then we'll go virtually, since there's no one in Las Vegas. Ms. Jacobs, please proceed.
Good evening, Senator Doñate, members of the committee. For the record, my name is Cadence Matijevich, representing Washoe County. I want to be clear that my comments on the bill today are not about the policy of the bill. The Washoe County Board of County Commissioners has not taken a policy position on this bill, but I am here in the neutral position I hope I'm good with the rules, because we do have some technical things that we think are important for the committee to hear. I did have an opportunity to speak with the bill sponsor earlier this afternoon, and have made him aware of these concerns, and made my commitment to him that we would work with him if the bill moves forward, to work on these. And so, again, if it is the policy decision of this body to move this legislation forward, we have some concerns about the duties and authorities of coroners and medical examiners. Sections 3 and 4 partially address this, but unfortunately didn't get all the way there. And I would call to the attention of the committee a separate statute, NRS 259050, which is the coroner's duty to investigate. We believe that there are provisions within that statute that would likely need to be amended to come into alignment with this proposal. And so we would ask to be involved in those discussions, again, if it is the policy decision of this body to move this legislation forward. Thank you for the opportunity.
Good evening, Chair Donati, members of the committee. Joanna Jacob, Government Affairs Manager for Clark County. I concur with the comments with my colleague from Washoe County. I am also here on behalf of our coroner from Clark County with the same technical input that we have on this bill. We did also get the chance to speak with Senator Flores and the bill proponents on this, and are committed to working on some of these issues as should this bill move forward and as the bill continues to be considered. Again, on the issue in Section 3 and in Section 4, and also I guess on the duty of the coroner, and as well the maybe having a look at that NRS 259 and the duties of the coroner, because we do investigate causes of death and that may be unrelated to this decision by a patient, and wanted to make sure it just conforms with that duty that we have in the statute. So again, not here on the policy of the bill, but more on a technical concern, and so we are neutral. Thank you very much.
Thank you so much. Anyone else in neutral for this bill in Carson City? We don't have anyone in Las Vegas. Anyone virtually?
If you would like to testify in neutral for SB 239, please press *9 now to take your place in the queue.
Thank you, Chairman Dunyate. My name is Wiz Rizard. I'm actually testifying as a private citizen regarding this bill in neutral. I applaud the bill sponsor for bringing this forward, as it is a very important discussion and a balancing act between individual rights and, more importantly, vulnerabilities. And I think my question that I have for the bill presenters is in Section 23, Article 1, where it says at least 18 years of age. My question is, why not a minor, let alone a minor who's been emancipated? Why aren't they included? Also, in terms of number 2, diagnosed with terminal condition and shows competency. I'd like to know, how is competency determined? I believe someone else mentioned it, a psychologist mentioned it. I think that's a very important thing to clear in terms of how do you determine that and who determines that. In terms of the prognosis, I see there's 2 physicians. Why 2? Why not 3 or 4? And then with Section 24, are there any guardrails for individuals who might be indecisive? 1 minute they want it, last minute they pull out. 1 minute again they want it, last minute they pull out. Do we have any guardrails or processes to ensure that the individual is actually firm and competent in making the decision? I greatly appreciate the bill being brought forward for discussion, and thank you, Chairman Donate, for this time to show neutral on Senate Bill 239. Thank you.
Good evening, Vice Chair and committee.
I was waiting to testify in opposition online, and I never heard that call. Did I miss that?
Unfortunately, we have already passed the opposition time. We are now in neutral.
All right. As I said, I did not hear that opposition called. I have 1 minute of testimony to give, if that's allowable.
Thank you so much. You can submit the testimony in writing, and we'll be happy to review that and send it out to the committee members if you can contact our committee secretary. BPS, is there anyone else in neutral on this bill?
If you would like to testify in neutral for SB 239, please press *9 now to take your place in the queue.
Hi, my name is Lisa Partee, P-A-R-T-E-E, and I'm not neutral. I'm just, you guys totally
I'm
skipped
sorry,
the opposition
BPS,
via phone.
we are currently in neutral right now, so if there are any other individuals that would like
Yeah,
to
I know,
testify,
you just said
BPS,
that
if you can please mute. We are currently in neutral testimony. If you would like to provide testimony either in support or in opposition, you can send it to the committee members at this time. BPS, is there anyone else in neutral?
Once again, if you'd like to testify in neutral, please press *9 on your phone to take your place in the queue.
I just wanted to mention to all the legislators there, the other two people are right. We never did hear that we could be in opposition online. So I apologize for nobody heard that.
Once again, we are currently on neutral. If you'd like to testify, please press *9 on your phone to take your place in the queue.
I'm just sorry. I just picked up the phone. This is opposition, right?
Unfortunately, we have passed the time for opposition. We are currently in neutral on this bill.
Okay. Well, just the way.
And we encourage you to please submit your testimony in writing so we can have the chance to read it. BPS, is there anyone else, once again, in neutral for this bill?
Once again, if you'd like to testify in neutral, please press *9 on your phone to take your place in the queue. Chair, there are no more callers for neutral at this time.
Thank you so much. In general, from the bill presentation, Senator Flores, if we can go ahead and do one more round of questions, if you are comfortable doing that, I think there are a few rounds, including myself, that I would like to make sure that we're clarified. So I would go ahead and invite you back so that we can give the senators at least one more instance to either address any concerns that came in during the testimony. And I will go ahead and start when you guys are ready. Okay. So quickly, we heard patient privacy as a concern, and I think that is a very valid concern with this particular legislation. There was concerns about the HIPAA Act and what that could look like. Is that something that has been raised in other states in regards to patient privacy? Is that something that, is there validity to that?
Yeah, thank you, Senator. My name's Samantha Trad. The way that we protect patient privacy in part is by making sure that the death certificate lists the underlying illness so that they cannot be identified. And that also helps the CDC record so that, people who are dying from different terminal diseases are rightfully counted. in their collection of data.
Thank you. And then just a question. I know that we talk about civil immunity for the physician that provides this service. Are there cases that we have seen in other states where perhaps the patient is angry at their physician for not prescribing this medication, because at the end of the day, it is the physician's authority to do so? And have there been, is there instances where they proceed forward with lawsuits? Is that something that happens in other states, or what has been that encounter?
Yeah, Samantha Trad. So the law protects physicians. They're allowed to opt out. So patients can't do that. So if their doctor decides not to support them in this, then they have to find a doctor who will.
Thank you so much for that clarification.
Yeah.
I'm good on my side. Dr. Titus.
I am so glad you asked that question, because I call contrary to what you just stated. In Section 37, it distinctly says that the provider, if they are not willing to do this, must, and the word is must, refer the patient to somebody who will. So does that mean I have to keep a list in my office of doctors? And if I don't do that, what will be the consequences? Page 17, line 7.
Samantha Trad. So the doctor is not required to support the patient through the process for medical aid in dying. And it's really important that a patient doesn't fall through the cracks, that they're able to be supported so that they can find a doctor who will support them. So that's why the doctor should refer the patient to a doctor who will support them, to a practitioner who will support them.
Okay, I understand what you're trying to say, but what this says is, it's not that I shall or I may, it says I must refer them to somebody, and then it doesn't clarify that if I'm not willing to do that, that what's the civil liability if I don't support that patient's choices? Are they going to sue me for denying them access? Am I liable by this wording in this paper, in this bill?
I need to check with our policy because
Name for the record.
Samantha Trad, for the record. Thank you. I watched all the past hearings of this and I forgot to do that. I would want to make sure that I give you the right answer. So I want to go and research that and provide it in our written testimony.
Thank you so much, Senator Stone.
Thank you. And again, I have tremendous empathy for those that have got a terminal diagnosis. I was with my mother until the very end, 57 years old, died of metastatic breast cancer, making sure my mom was comfortable and she was comfortable until the end. So one of our doctors testifying today mentioned, what do you do in a case where somebody has a spinal cord injury, has no use of their arms, legs, or I had ALS that's been said that they're terminal. The legislation says you must self-administer. How would somebody that has these disabilities self-administer these drugs?
Yeah. Samantha Trad, thank you for that question, Senator Stone. So the eligibility requirements I talked about at the beginning are really important. The patient has to be able to self-administer the medication. So there's 3 ways that generally happens. One is the patient can drink the medication. Another is if they have a feeding tube, they have to be the one to push the plunger. And then they can also use an anal catheter as long as the patient themselves is able to push the plunger. And so that's how patients with ALS are able to access the law.
Okay, so who?
If they, they go through the steps and they qualify.
Yeah, okay, so who administers the liquid into the feeding tube, or they can't do it themselves, and, rectally it's very unpredictable what your absorption is going to be, and you could actually have a significant reaction where somebody has a prolonged death because they didn't absorb the drug appropriately.
Yeah, so that's between the patient and their practitioner to talk about what, how they're going to do it. This is why we don't want to legislate medicine either, because medicine changes, every patient's different. There's not just one end-of-life medication. We need to make sure that the right medication is prescribed, and so that's why we trust the practitioners to determine that with the patient. Samantha Trad, did I say that? I think I did. Okay.
So are you saying that the cocktail that is going to end somebody's life is under the purview of the doctor? It can vary from doctor to doctor. It's not pentobarbital or atropine. It could be something else.
Yeah, it's up to the practitioner
And for the record.
Samantha Trad. It's up to the practitioner it's their responsibility. They're the ones who are treating the patient. So they are the ones who have, in order to be qualified to be the attending or consulting practitioner, they need to be qualified to diagnose the terminal illness, the prognosis, and so they have that knowledge so that they can do it. And we also have a doc-to-doc consultation line, so a doctor can talk to another doctor who has prescribed medical aid in dying, like Dr. Carroll, who was here earlier and has supported many patients in this. There's a lot of doctors who have a lot of experience supporting patients in aid in dying who we can connect doctors with, and they can mentor them if they have any questions.
Okay.
For free.
And lastly, if I may. So in Oregon, they had a statistic a few years ago that said between 15 and 25% didn't die immediately, that it was a prolonged torturous episode for a loved one to deal with. So none of these formulas are 100% foolproof that it's going to extinguish somebody's lives in a short period of time. So, and lastly, I want to just bring up one example. A gal, the name initial B. Wagner, from Oregon, 64-year-old, diagnosed with lung cancer. A new drug came out that improved the efficacy and survival of breast cancer people by 30%. And the Oregon Medicaid had to be consulted because the cost of the drug was $7,000 a month. And the letter that the patient received from the state of Oregon said that they would not cover this drug, but they would cover an assisted suicide drug. I hope that if this does pass in Nevada, that we don't send letters like that out to people and encourage their committing suicide when there's viable treatments to maybe save their life. Thank you.
Sarah Mance for the record. Senator, I hope so as well. The complex question, as you and I have discussed in other conversations, of how state Medicaid formularies are determined and who determines that is what would be driving that. And it is, I know, having sought care for my own rare cancer, that insurance companies deny treatments constantly. This happens all the time. And unfortunately, when you're facing a serious illness, it's the worst time to have to fight about it. It is a serious problem in our system, and it has to do with the cost of prescription drugs more than anything. Unfortunately, I don't think it has that much to do with this policy, and the idea that they sent that is shocking, but not surprising. Thank you.
Thank you so much. One last question, which I will go ahead and give. In the testimony, we heard the discussion between competency and capacity. What is the feedback that you have had in other states of that conversation?
Senator Edgar Flores, for the record. I just want to address competency in general. This is not something new to the medical community. There is now a whole host, and people will talk about competency in palliative care, comfort care, hospice. There's a whole host of medicine already around this conversation, body of literature. What is competency? And I know through my hat as an attorney, we even have these conversations in court. Is somebody competent to stand trial? There is no perfect formula to that. But when we're talking about what is competency, the medical community will tell you, I'm sure, varying definitions of that from doctor to doctor. I'm not pretending that there's this perfect definition, and Senator Titus can speak to this. But I know for a fact, in speaking with the medical community, that there is this general conversation that's happening whether or not somebody is competent or not, and which is why this is so important that we have two separate doctors having this conversation as well, because they're also making that assessment, right? They're not just looking at this individual and saying, do they have a 6-month or less prognosis? Is there a terminal illness? But they are also simultaneously having a conversation about, is this individual competent to engage in this conversation? So my point to that is competency, while I am not pretending I can give you a specific definition, and perhaps speaking with our legal division, they might be able to give us a specific section in the NRS if there is a definition to it. My understanding, and having spoken with the medical community, it is a conversation that's constantly always happening. And when a doctor realizes this individual is not competent, they're speaking to the family members, they're speaking to the guardians, they're speaking to a whole host of other individuals. That is a constant assessment that's always happening, not just in this dialogue, but always in the health community.
Thank you so much. Did you want to say one more comment? Before?
Yeah, Samantha Trad. I just wanted to add that both the attending and consulting practitioner will work with the patient. They will go over competency. And like the senator said, this is language we're looking at in the bill. I think there were some things, I don't know what happened with the drafting, but we're working on the language to make sure that it's correct before you vote on it. And so if there's any question about the patient's capacity or competency, they can refer the patient to a third evaluation by a mental health specialist. So this is something that both the attending and consulting practitioners are qualified in to evaluate the patient. So they're going to go through 2 different evaluations already. And then if there's any question, they will refer the patient.
Great, thank you so much. And before we go to closing comments, Senator Flores, I just would like to request from the folks that helped you prepare for this bill presentation, I think it is important to address the instances of what Senator Titus was alluding to, which is the obligations for a physician and the freedoms that they also have in this capacity. And I think that's something that has to be addressed if you proceed with an amendment. So I think that concludes the majority of our questions, but if you have any closing remarks, now would be the time.
Senator Edgar Flores, for the record, I first wanted to say thank you to everybody who stayed behind. I know it's late hours, and I really appreciate everybody engaging in this dialogue, whether or not they support the bill or not. I am appreciative of them engaging. Second, thank you, members, for the questions. We're working with folk now on addressing some of the questions that were brought up, particularly Section 3, also working with the coroner's office. And we are committed to ensuring that this bill comes out as clean as possible. I mean, there could be a hypothetical, even in Dr. Titus's question, that what if no physician in the state of Nevada wanted to do it, right? There's a conversation of how do we refer that? And so the intent here is not to create a harm for the physician, but rather for a protection for the dying, suffering human being, to ensure that if one physician cannot help them, that they're being referred somewhere else. What we don't want is a conversation to end there. That was the point of that section, and that's why we put it there. But it was by no means a jab or a grab at the physician. We understand that not everybody will agree with this conversation, and we're 100% committed to protecting the physician's right to say, no, I'm not going to engage in this area. We think not using this, by the way, I just want to remind folk, not using medical aid in dying is using the bill. Nothing in this bill requires any single human being to do anything. This is only creating an option for some human beings who will have a right to say when too much suffering is too much suffering. That's all this bill is aimed at doing, and again, I appreciate you all for staying so late into the hours with us. Thank you.
Thank you so much. At this time, I will go ahead and close the hearing on Senate Bill 239. And we will now move to the last agenda item, which is public comment. So we'll start from the physical locations and then move to anyone who has called in. And of course, we remind everyone to limit your comments to 2 minutes each. This is not a moment to talk about policy. This is where you can talk about not policy that has been discussed in this meeting, but we will give folks the option to go ahead and come forward if they would like. Anyone in Carson City? We don't have anyone in Las Vegas, anyone virtually?
If you would like to provide public comment, please press *9 to take your place in the queue.
Good evening, committee. My name is Jim DeGraffenreid, DEGRAFFENREID, and I'm commenting as a private citizen. Without referencing any bill in particular, I want to express my disappointment with the process and fairness of the process. When hearings are scheduled on short notice, well after the deadline for submitting written testimony is passed, and in conflict with other meetings in order to give advantage to supporters and make it as difficult as possible for opponents to be heard, it makes a mockery of the language in the bill that reads, "The people of the state of Nevada represented in Senate and Assembly." When only one side of the bill is represented or given an opportunity to participate, the results of the process will be suspect, and this benefits nobody. This lack of fairness and transparency is not limited to any particular bill or committee, nor even to this session, as we remember numerous major bills in 2019 and 21 that were heard without notice and therefore did not receive fair hearings or proper vetting as well. I hope that this committee and this legislature will work toward a more transparent process that will foster respect for the results going forward. Thank you.
If you've just joined and would like to participate in public comment, please press *9 on your phone to take your place in the queue.
Hi, thank you for allowing us to call in again for some testimony. Again, my name is Lisa Partee, P as in Paul, A-R-T as in Tom, E-E. I am opposed to SB
I'm sorry,
239.
at this time, BPS, we are currently in public comment. The time for commenting on the legislation has passed. We are no longer doing testimony for Senate Bill 239. This is public comment. So if there are other comments that you could like, now would be the time. BPS, is there anyone else in public comment?
Yes, I'd like to make public comment. My name is Leslie Quinn. I just wanted to say it's just disturbing how our state, country, and our government is becoming more and more immune to telling the truth and just as okay with lying. And I just wish that we wouldn't. We would stand up for honor and we would have more moral and integrity in all things that we do. Thank you.
Chair, there are no additional callers at this time for public comment.
Thank you so much. That concludes today's meeting, and our next meeting will be Thursday, March 16th at 3:30 p.m. Meeting is adjourned.